This presentation is titled "The Influence of LV Stimulation Site on the Spatial Distribution of Conduction Slowing, Implications for Substrate Mapping of SCAR-related Ventricular Tachycardia." SCAR-related VTs often depend on areas of slow conduction in the so-called infarct border zone. These areas, known as critical VT isthmus, often also exhibit slow conduction during sinus rhythm. Thus, substrate maps generated during sinus rhythm can aid in guiding VT ablation. However, the functional substrate is qualitatively different during VT than during sinus rhythm. Therefore, there is really no reason to think that sinus substrate maps alone will tell the whole story about the VT functional substrate, at least not in every case. We hypothesize that substrate maps generated with multiple different pacing wavefronts can reveal additional areas of slow conduction and thus offer additional clinically useful information about the VT circuit. So the specific study goal here was to examine the influence of the direction of LV activation slowing and to correlate these sites with the VT isthmus. We used data from Physio-VT, a prospective multi-center study of patients with infarct-related cardiomyopathy who underwent a VT ablation. All of these patients underwent LV activation mapping during atrial pacing or sinus rhythm, RV pacing, and LV pacing. Now, the goal of these substrate maps was to identify regions with slow conduction, where the apparent endocardial velocity was 0.25 meters per second or less. Now, this translates to an inverse velocity of 40 milliseconds per 10 millimeter or more. And the reason why we work with the inverse of velocity is purely practical. Electroanatomic mapping systems allow for the visualization of endocardial activation times in terms of isochrones. For example, when isochrone width is set to 10 milliseconds, any location with 4 or more isochrones within a 10 millimeter segment will be a region of slow conduction. Anytime a VT was induced, the arrhythmia was either mapped or entrained in an attempt to define the location of the critical VT isthmus. And finally, we correlated areas of slow conduction with the physical location of known VT isthmuses. The Physio-VT study enrolled 85 patients. Substrate mapping was done using 2 to 3 wavefronts, on average 2.4 wavefronts. Specifically, over 90% of patients were mapped during sinus rhythm or atrial pacing. RV or LV pacing was done in over 95% of patients. And all the 3 possible pacing wavefronts, sinus or atrial pacing, RV pacing, and LV pacing, were used in 43.5% of patients. Endocardial slowing was seen in 91.8% of patients. There was an 84.2% spatial overlap in the areas of slowing seen during sinus rhythm or atrial pacing and RV pacing. There was a 71.3% spatial overlap of slow conducting areas in RV paced and LV paced maps, and the least amount of spatial overlap, only 61.4%, was seen when comparing maps generated during sinus rhythm or atrial pacing and LV pacing. Now, sinus rhythm or atrial pacing alone identified about 2/3 of all slow conducting areas. In the Physio-VT study, there were a total of 204 VTs observed. Of these, 36 or 17.6% could be entrained or mapped, thus providing us with the location of the putative critical VT isthmus. Substrate maps generated during atrial pacing, sinus rhythm alone, identified 21 out of 36 or 58.3% of the VT isthmus sites. Combined substrate maps generated using 2 to 3 pacing wavefronts identified 31 out of 36 or 86.1% of the VT isthmus sites. This slide shows maps from a patient with a large anterior scar in whom multi-site pacing was particularly helpful. The first panel shows an activation map generated during atrial pacing. The area of slow conduction is delineated by a black box and highlighted by a triangle. Note that this region does not coincide with the site of latest activation, highlighted with a star. Also of note is the fact that the slow conducting areas often exhibited complex fractionated electrograms, as seen at the bottom of the figure. Now the middle panel shows that slow conduction during RV pacing falls to an approximately similar location. However, when pacing is performed from the left ventricle, as seen in the left panel, slow conduction moves to a more apical location. This slide shows voltage maps from the same patient using atrial pacing, RV pacing, and LV pacing. The regions of maximal conduction slowing are highlighted with a dashed line and appear to coincide with the border of the low voltage islets. Note that the low voltage region is qualitatively different in the LV paced map, and again that the area of maximal slowing is also very different from what is seen in the atrial paced and RV paced maps. This patient experienced a ventricular tachycardia with a cycle length of 224 milliseconds. The tachycardia was mapped and mid-diastolic potentials were identified in the highlighted region. Note that this region coincides with the region of slow conduction during LV pacing, but not during atrial or RV pacing. Ablation in this region slowed and then terminated the tachycardia within 7 seconds. In conclusion, we have shown that the location of activation slowing depends on the direction of LV activation. Sinus rhythm and atrial pacing alone reveals only about 2/3 of all slow conducting areas. Also, only about 58.3% of proven VT isthmus sites fall into slow conducting regions identified on sinus rhythm or atrial paced maps. However, when multiple pacing wavefronts are used, as many as 86.1% of VT isthmus sites correspond to a slow conducting region on at least one of the substrate maps. Therefore, substrate mapping techniques incorporating pacing from multiple directions increase the sensitivity for identifying VT isthmus sites.